other options. Another option, a feasible option, is arthrodesis. Now, this is a boy who underwent arthrodesis, turnoplasty. You see a nicely healed bone for an osteosarcoma of the upper end of tibia. Their average score is nearly the same as that for endoprosthesis. But of course, I agree, they're not able to do many things like sitting in a car. But my patients really don't need to sit in a car that frequently. Or there are other biological options like fibular grafting. That's an extraphyseal resection. Patient is doing well, but he will have issues with growth later on in life, which need to be tackled. And of course, we have our own papers on locking plates and their roles in oncological reconstruction. But limb salvage surgery doesn't stop there. It doesn't stop with the surgery. You need to keep a surveillance after salvage. And such a report showing 90%, more than 90% of tumor necrosis is a very happy news for you and for the patient, because you know that those patients who have responded well to neoadjuvant chemotherapy and to chemotherapy and has more than 90% necrosis are going to do well in the long term, and they are very good candidates for limb salvage surgery. So what are the conclusions? Limb salvage is an orchestrated sequence of events leading to complete tumor excision without compromising limb function. Feasibility of limb salvage depends on the patient, on the tumor, and on the surgeon most importantly. When I say surgeon, it means the infrastructure. Achieving surgical margins are the single most important determinant of local recurrence in limb salvage surgery, and that is important. This gentleman is Alvin Toffler, the author of Third Wave and Future Shock, and he says the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. Thank you.
Had the same treatment, except for if the tumor was up against these neurovascular structures in history he was looking at. He compared doing a radical resection of all the vessels and everything that was involved versus doing a limb salvage and actually accepting a microscopic positive margin, but still continuing adjuvant treatment. There's no difference in the survival of those patients. And so what he's saying is that it's probably more innate in the disease whether you get that local recurrence. Now this is soft tissue sarcoma, but we're talking about huge, huge tumors. There was no difference between the two by accepting a little bit less margin as long as you properly treated that margin. And I think I'm saying it's a little different than bone sarcomas, because bone sarcomas, I think it's more surgically important because you're not doing radiation with those patients. But still, I agree with his treatment. Limb salvage surgery is, if you can resect this thing and get clear margins and have a functional limb, I don't think there's any difference. The patient's survival is based off that chemotherapy. I got one question for you, though. I thought it was a great talk. We don't do too many arthrodeses in the United States for a variety of reasons, but I was wondering, the reason that you all do more here, is it solely because of cost, or is it also because maybe these patients are going to be more hard laborers in the type of work they have to do, that would they be better off with an arthrodesis?
Both things are interlinked here in this family. So if you're poor, you're actually probably working in the field. If you're rich like Manish, you're running. The thing is, sorry. So the thing is that Manish is a proponent of endoprosthesis. We just had a talk about 1 week back, which I haven't finished. So arthrodesis actually, arthrodesis is a cost-effective measure, and we do it because of price. Number one reason. Number two reason we do it because of price. Number three reason we do it because of their institute is a semi-government, and we have a pure government setup where we have to go through the NGOs, we have to go through the social service offices. So it's really a pain to bring that money to a prosthesis. But we do that. I mean, we had in our series we have 54 prostheses and 34 arthrodesis, so that shows the difference. In fact, over the years we are doing more of prosthesis than, but there are issues. What happens 10 years down the line if that prosthesis fails or it becomes loose? I mean, I don't know of any prosthesis which can last a patient's lifespan. So, but I know of arthrodesis which can last a patient's lifespan. So once the prosthesis gets loose, he goes again through the same process, and I will go through the same process of, beg, borrow, and steal. So it's basically finances, whatever you may say at the end of the day.
But, and you're probably right, and we'll get into more of this tomorrow because we're going to talk about a lot of limb salvage surgery. But the thing I'll challenge you on is that, in looking back at the data, there's early complications with allograft arthrodesis, late success.
We do very little allograft arthrodesis.
But like
most of it is autograft, either fibula, both the fibulae.
Oh, so you're talking about doing
previously people
Autogenous,
were using
yes.
allograft. So I mean, I have waited. We use allograft as morcellized graft to put it and pack it in the cavity that is created after that arthrodesis.
But we'll get.
If your length is going to be more than 15 centimeters, then you have more complications. But otherwise,
Right.
Absolutely, agree there.
But we'll get into more tomorrow. We got a lot of different prosthetic and reconstruction surgeries tomorrow, and we probably need to get going on this next
We
session.
can offer you for that Obamacare, you know. We can
Okay.
teach you.
On cartilage tumors, we've already had a lot of discussion of cartilage tumors, so we may well continue on the discussion with cartilage tumors. And the cartilage tumors and how we're going to look at these, they're very common tumors. And as Dr. Temple always says, he could put his kids through school just by treating cartilage tumors because we see so many of them, and we follow them for long periods of time because many of them we don't operate on. But they're heterogeneous tumors. They have a lobular growth pattern. That's one of the things to really pick up. Two tumors that commonly lobulate are fatty tumors and cartilage tumors. So it helps you with your differential diagnosis when you see a tumor that's lobulating, that's growing. It's also matrix producing the arcs and rings, and on the MRI scan, high water content. And these are all important things that you want to look at when you're trying to work up a diagnosis. So we're going to look at the classification of cartilage tumors. First, benign, more reactive, or benign lesions such as hamartoma, and then true neoplastic tumors are the osteochondroma, the chondroma, chondroblastoma, and chondromyxofibroma. The malignant tumors we're going to look at here are chondrosarcoma and some of the variants of chondrosarcoma. But we'll start off with a straightforward, easy tumor, osteochondroma. In osteochondroma, it is a tumor that it's a defect in the perichondral ring and during the growth plate, and some of the rest cells continue on from the growth plate. The growth of this parallels the normal growth of the bone because it's actually a part of that growth plate that's extending out. They don't really cause much problem. They can cause some pain, and there are usually two types that we talk about. There's a sessile, the first one you see there, and there's the pedunculated. The sessile is a little bit more difficult to diagnose when you're looking at these things because they can get confused many times with paraosteals and things like that. But the key to diagnosis is really the corticomedullary continuity. And then you can see there, the cortex goes up into the lesion, the marrow flows out into the lesion, and that's corticomedullary continuity. Nothing else has that, and that really gives you the diagnosis of an osteochondroma. So when we see osteochondromas, they represent about 8% of all bone tumors, however 35% of the benign bone tumors, 34% of the cartilaginous tumors, and we see a majority of these around the knee. Most all of the, even osteosarcomas and things like that, around the knee. So the knee is a problem, and as Dr. Rosenberg said earlier, it's probably because of the high rate of growth around the knee as that child is growing, especially during that growth spurt. So most of these are metaphyseal. They have a low recurrence rate in taking these things out. And the big concern is that there's about a 2% malignant transformation, and I think that's really even debatable of what that rate really is. So again, just another picture of the corticomedullary continuity and why these things cause pain, and that's really the problem with these things. I rarely treat osteochondromas unless they have some sort of symptoms, and I treat the symptoms and not necessarily the lesion. Many of the times patients will present with tendinitis, bursitis. They can fracture these things. You can even get neurovascular compression, osteonecrosis, and the big concern is malignant transformation. I'll just show you some of the examples of the problems. You can get fractures of these things. Here's a fracture of an osteochondroma, and if you do get a fracture, normally it's best to go ahead and just take that broken piece out. It's a pretty easy surgery to do, although these things will heal if you leave them alone. You also get neurovascular compression, and you can see one pedunculated one putting pressure on the neurovascular structures, and those are the ones that more commonly will need some sort of surgical treatment to get some pressure off those neurovascular structures. Here's another one up against the perineal nerve. And if they're not symptomatic, I probably would leave that alone, because just resecting that and injuring the perineal nerve is a problem. But if they have perineal nerve symptoms, you certainly want to go ahead and remove that so they don't progress. But this is one of the most common one we see is pes tendinitis. You get these things along those pes tendons, you're usually better off going ahead and removing that lesion, because they're going to continue to have symptoms, especially if they're athletic. Then you can see problems with deformity, and here you can see the ankle joint is significantly deformed, causing significant arthritis. This probably would have been better treated by resecting it earlier on and try to correct the deformity.
Now, the osteochondroma grossly has three major components: the outer fibrous layer, which is the perichondrium, the underlying cartilaginous cap, and the bone that forms from the process of enchondroossification. A lot of attention has been given to the thickness of the cartilaginous cap, because early literature and studies arbitrarily defined a cartilage cap 2 centimeters thick or greater is considered to be a chondrosarcoma arising in an osteochondroma. Personally, I use histologic findings to distinguish a thick cartilaginous cap of an osteochondroma from a chondrosarcoma that's developing, again, in the background of an osteochondroma. Now here you can appreciate the cartilaginous cap, maybe 1.5 centimeters in thickness. This underlying tan tissue and white tissue represents the enchondroossification with the formation of bony trabeculae and fatty marrow. Dr. Letson mentioned the possibility of a defect in a periosteal ring that's leading to the development of these, but molecular studies have shown consistent translocations in either the EXT1 and 2 genes, which would suggest the possibility that it's really a neoplasm of the chondrocytes, and that cartilage undergoes enchondroossification, so the cartilage is neoplastic and the bone is not. Example of an osteochondroma, which much of the cap has already undergone almost complete enchondroossification. This is the type you see in one that has ceased growing. Now, histologically, the cartilage cap of the osteochondroma recapitulates that of a growth plate, albeit there is a greater amount of disorganization. So we're looking at something that resembles a zone of hypertrophy at the base, undergoing enchondroossification, newly formed bone with islands of residual cartilage.
This is why I love doing lectures with Andrew. I can sit here and listen to him and learn something while I'm giving a lecture with him. So, osteochondromas, again, skillful neglect. You know, we try not to operate on these things. We cause more complications by operating on them. However, symptomatic lesions, especially recurrent symptomatic lesions, is why we would resect these. Okay, so usually the deformities you see with these osteochondromas are adductor deformities is what they cause, especially around the distal tibia, around the ankle. But there are adductor deformities, and again, you have to be concerned about malignant transformation. When you see these osteochondromas around the epiphysis, they're called dysplasia epiphysealis hemimilica, or Trevor's disease. These are rare diseases. They usually involve the joints. They're different than osteochondroma, and they actually point towards the joint, whereas most metaphyseal osteochondromas point away from the joint. They cause a lot of pain and deformity, and usually you need to resect these. And the problem is when you try to resect these things, they involve somewhat of the joint, and you're going to affect the joint. And I'm going to show you an example here of this epiphysealis hemimilica involving the talus and the problems that it has when you're getting back to resecting this thing. So you can see here this corticomedullary continuity coming out off of the talus there. And you get a better look at this thing, and you can see it's jamming up against the joint, so it's going to cause damage to the distal tibia. So you can't let that continue on, and when you get a better look at this thing and follow it around, you can see that it's up against the talus and then going around towards the fibula. So you're going to need to resect this thing in order to preserve the joint. So rarely do I let these osteochondromas go. These are ones in order to save the joint, I will treat early. Okay, moving on to chondroblastoma. So chondroblastoma is one of the lesions we talked about earlier. It's a epiphyseal lesion. So lesions of giant cell tumor, clear cell chondrosarcoma, chondroblastoma are epiphyseal lesions, and you need to always think of those together with the differential. Chondroblastoma, however, occur more earlier on in life. Usually the growth plates are open when you see chondroblastoma compared to giant cell tumor, where the growth plates are usually already closed off. Chondroblastoma is a little bit more common in the males, occur usually, like I was saying, in that first 2 decades of life. 95% occur before 25 years of age. Majority of them, again, occur around the knee. That's not unusual for these lesions. What they are is these, they're radiolucencies. They have a sclerotic border, so they have a 1A border surrounding them, and about 50% of them have that. And I always look at that because giant cell tumor rarely ever has a 1A border, and clear cell chondrosarcoma has usually what we call a 2A border, or that wide zone of transition. So it's a different way of differentiating those. 20% of these will disrupt the subchondral bone, so they're going to cause some damage to the joint potentially. And you can usually see some mineralization, some stipple mineralization with the cartilage within that. And it's not uncommon to have a fusion because these chondroblastoma have so much edema surrounding them. That's why they're a painful bone tumor. It's one of the few bone tumors that is painful, and you can see that with the edema surrounding the lesion. So here's the chondroblastoma of the posterior elements. Most of the time when you see chondroblastoma, they are in the posterior elements. They're eccentrically placed. One thing is what I've talked about earlier with these benign lesions. You can see that there's, even though there's some elevation at periosteum, the periosteum is complete all the way around this thing. So that's, again, represent like a benign lesion. As you look through this chondroblastoma here you can see the 1A border. You can see the stippled mineralization within the lesion, very consistent with a chondroblastoma. You can see it's completely located within the physis or the epiphysis there. And you can see that black rim around it on the MRI scan consistent with sclerotic border. Here's a nice case that I like that really typifies a chondroblastoma. You can see the 1A border surrounding this lesion here. You can see a little bit of stipple mineralization with it. You can see it approaching the subchondral plate, and you can see on the CAT scan it's actually breaking into the subchondral plate. We were saying that it's not uncommon for chondroblastoma to do that. Giant cell tumor more rarely goes into the subchondral plate. But you can see by the CT scan those stippled mineralizations show up much better. When you look at the MRI scan, look at this edema surrounding it. This is a stir-weighted image. You get that edema surrounding this very high signal in the T2 weighted image. You can see the high signal here in that joint effusion. All that's very common with chondroblastoma. This is a classic appearance of a chondroblastoma. Now, chondroblastoma also can occur in the foot and ankle, and when you see it in the talus, it's interesting. Remember we talked about location earlier today. Location is important, not only which bone it is, but where in that bone it's located. When you see tumors that are at the junction of the center of the talus here, these are usually bone cysts that occur at that central portion. When you see it at the apophysis, again, that means chondroblastoma, and as we'll talk about earlier, lesions that have aneurysm bone cyst-like presentation, chondroblastoma is in that differential, and you can see here's this fluid of like an aneurysmal bone cyst, but this is actually apophyseal in location, which makes it into a chondroblastoma. So typically, chondroblastomas are less than 5 centimeters in size. They lobulate like all other cartilage lesions do. They rarely have ossification in it. 12% of the cases will show some necrosis, so you have to be careful of that pathology. Secondary aneurysm bone cysts, as I just said, a third of them present with that.
So chondroblastoma is generally a hypercellular neoplasm. The neoplastic cells are polyhedral, have well-defined cytoplasmic membranes, moderate amount of eosinophilic cytoplasm. As we'll see when one looks carefully at the nuclei, unlike the chondrocytes in an enchondroma, which are small and round, these are usually larger and have irregular nuclear contours with nuclear clefts. Importantly, they make cartilage, but usually very small amounts of what appears to be primitive hyaline or fibrocartilage. Frequently, that cartilage can mineralize surrounding individual cells, imparting the so-called chicken wire-like pattern of mineralization. As Doug mentioned, chondroblastoma is one of several group of primary bone tumors which may have a lot of osteoclast-type giant cells, at least raising the differential diagnosis of giant cell tumor of bone. This is a touch prep from a chondroblastoma, just nicely demonstrating the nuclear clefts, which really are like a coffee bean as a big fold is occurring within the nuclei. Another example of the small amount of hyaline-type matrix, the nice mineralization surrounding the individual cells, again, giving that chicken wire-like pattern of mineralization. You can get some reactive fibrosepty within the tumors, and as well innumerable giant cells which can raise a differential diagnosis of giant cell tumor of bone.
So the treatment of chondroblastomas, these are not something you follow. You need to surgically resect these because they will continue to grow and they can be very large in size. There I have about a 27% local recurrence rate, so you need to do an aggressive curettage. Consider cryotherapy. I personally don't do cryotherapy unless they have a local recurrence because I do not want to damage the subchondral area. These are young children or the physeal plate. Malignant transformation is rare, but if you have that, again, wide resection. So we're moving on to chondromyxal fibroma. This represents 2% of the benign bone tumors. They're relatively rare bone tumors. Usually occur in the metaphysis of long bones, most commonly around the proximal tibia. 2/3 occur in the tubular bones. You rarely see them in the flat bones.
These tumors do not have a specific molecular abnormality, but there have been reports of a variety of different derangements involving chromosome 6. This is an example of a case that had an interesting translocation between chromosome 6 and 9, but again, this is not a consistent finding. The most frequent abnormality, though, are derangements in chromosome 6.
And here's the case I discussed earlier. I use it because it's a classical chondromyxal fibroma. You can see this 1A border around this lesion. You can see the high signal content of a chondroid and a myxoid lesion on the stir-weighted image. And again, you see that 1A border around this. Here's other examples of chondromyxal fibroma. They can be larger. And here's one you can see in the distal femur. Again, you can see that 1A border around the distal femur. They're always eccentrically placed. Again, that's very important, looking at the location within the bone. And here you can see a chondromyxal fibroma of the digit of the finger.
Now, grossly, these lesions, like most benign primary tumors, are well circumscribed. They're usually tan, pale yellow, glistening neoplasms. This is an example of one that has been curetted out with some adjacent blood clot. Histologically, again, correlating very nicely with the gross and the radiographic imaging studies, they are well circumscribed. Here we see the junction between the lobules of the tumor and the endosteal portion of the cortex. Chondromyxoid fibroma has unusual histologic features. As the name implies, there are regions that resemble cartilage, where you have chondrocytes in lacunar-like spaces, myxoid tissue, where you have stellate cells floating in a more mucinous stroma. In my experience, the fibrous component, which is the least present in amounts and frequently just consists of some fibrous septate. Here is a chondroid area, cells in lacunar spaces. Here the cells are spindling out, and some of the dark coloration represents some blotchy mineralization. More myxoid region with stellate cells residing within a mucinous stroma. One other interesting finding in chondromyxoid fibromas, cartilage is generally avascular. Certainly normal, in the normal situation, cartilage is avascular. Enchondromas are avascular. Conventional chondrosarcomas are. Chondromyxoid fibroma is really the only primary cartilage tumor that contains a number of blood vessels, and you can see them here, and sometimes they can be, again, useful diagnostic feature. Most chondromyxoid fibromas do not contain a lot of mineral. When it's present, it's usually in these oval, irregular aggregates. It's uncommon for the cartilaginous tissue to undergo enchondral ossification.
Okay, so we'll switch back to one of the more common tumors, the enchondroma. We all know about enchondromas. It's a very common bone tumors, usually you see in the femur or the humerus. They represent about 3% of all bone tumors, but more importantly, somewhere around 12-13% of the benign tumors. The majority of these occur between the 2nd and 4th decades of life. At least that's when we pick up, because I think they're more active at that time. They usually present with some pain, and that's why you pick them up. They don't go away on their own, so I don't think that you're going to see less of them when you get to your 5th and 6th decades of life. I just think they become less symptomatic. So when you look at these, again, what I was pointing out before, they occur more commonly in the femur and in the humerus. The hands is the most common area, these benign enchondroma in the hand, but when we worry about more, because enchondromas in the hand are generally always benign. As they get more proximal, they're increased risk of turning into a malignant lesion. Remember, cartilage tumors and fatty tumors are the two tumors that you have to keep an eye on, because those will change over time. Osteosarcoma, once it's an osteosarcoma, it's always an osteosarcoma. But enchondroma, it's benign. It can become malignant, so you do need to follow these lesions. So this is what I do, because people always are asking. We had a long discussion today of what's a chondrosarcoma, how do you tell the difference between an enchondroma and a chondrosarcoma. So I don't believe there's one test, and that's why I was asking you, is like, can you predict a chondrosarcoma with nuclear medicine? And I don't think that we can yet. And I think that what I do is I look through these steps. I have all my residents, my radiology resident, orthopedic residents, go through each one of these steps, because each one of these is a clue. And you keep adding these things up. And the more positive findings you have with each one of these, the more likely it's going to be a chondrosarcoma. Any one of these by themselves doesn't mean it's a malignant tumor. So I think scalloping is something to look at. And I think it's important, if you look through Mark Murphy's system when they graded these things out, that chondrosarcomas usually had a grade 3 scalloping or higher. So when we talk about scalloping, less than a third is considered grade 1, up to 2/3 scalloping is grade 2. When it's greater than 2/3 scalloping, that's a grade 3 scalloping, and usually that's all the way to a break in the cortex, and that's, when you see a break in the cortex, to me, that is a malignant tumor. Compared to just scalloping by themselves. Mineralization is important too. In Mark Murphy's, that same paper, they talked about how much mineralization. When they saw less than 50% mineralization, there's an increased risk of that being a chondrosarcoma. The more mineralized the lesion, the less likely it is going to be malignant. Size was also important. They looked at size of these things, and less than 5 centimeters are more likely to be benign. When it got above 8 centimeters, they really are increased risk of being malignant, but anywhere from 5 to 8, you had a combination of benign versus malignant chondrosarcomas. But I think when you get to 8 to 10 centimeter cartilage tumors, you need to be much more concerned. But certainly the 5 centimeters, what the data shows, increased risk of chondrosarcoma. So this is something that Andrew and I both agree on, is the cortex. And thickening of the cortex doesn't happen in benign cartilage tumors of long bones. So when you see some thickening of that cortex, I think you need to be very suspicious that that is a chondrosarcoma. We also look at the bone scan, and we look at the activity in the nuclear medicine. The higher the activity, and what we look at is compared to ASIS, the more likely it is going to be malignant. So I was going through those. So here's just an enchondroma. This was right around 5 centimeters in size, and you can see that classic stippled mineralization, arcs and rings, classic of an enchondroma. We'll look at it a little bit closer with the CAT scan there, and you can see there's scalloping going on there. But the scalloping is grade 1, maybe grade 2 scalloping. That does not make this a malignant tumor. When you look at the bone scan activity of this, well, the activity of this is close to that of the ASIS, so something, again, I'm a little worried about, but we've been following this lesion for over 10 years and it has not changed in size. So this was an example of a benign enchondroma, and to me, a lot of that was the rate of mineralization, pretty much this entire tumor mineralized. So here's another one I'm a little bit more concerned about. If you look at this one here, although it's an enchondroma, it's larger than 5 centimeters in size, and there is at least grade 2 scalloping there. If you look at the CAT scan, again, CAT scan, I think that I can grade the scalloping much better. And you see some grade 2 scalloping, so I'm a little bit more concerned. The rate of mineralization is about 50%, but certainly there's some of it that's not mineralized. You look at the MRI scan, and some of the things I pick up on the MRI scan, there's no peritumoral edema. And I think peritumoral edema is another helpful thing, as we were talking about earlier, is that peritumoral edema is something you need to follow. So we've been following this one. Again, this one has not changed, but I'm going to make sure this patient is seen every year, because this one I think is a higher risk of heading towards what we really call a chondrosarcoma. This is what the patient here is what some of my friends would say, that's a low-grade chondrosarcoma, and you can curette that out. Well, you can curette it out, but we've done nothing and the patient's still doing fine. So I think those are the things we yet have defined. Cartilage tumors in the hands, in the feet, again, you can have grade 3 scalloping, you can even have a fracture of the cortex and breakthrough. These are benign tumors, benign cartilage lesions in the hands.
So grossly, enchondromas, as mentioned already, have a lobular pattern, meaning they're sort of a coalescence of round nodules of cartilage which are relatively well circumscribed from the adjacent bony trabeculae. There's a larger enchondrome in the distal femur. These white areas represent mineralization of the matrix, as well as some enchondral ossification of the periphery of some of the lobules of the cartilage. This is a resected proximal fibula, just highlighting an important feature of benign primary bone tumors, in that they have a very sharp margin between tumor and the adjacent non-neoplastic bony tissue. It can be very irregular and jagged, but a sharp margin I can draw where the tumor stops and the non-neoplastic tissue begins. Also demonstrates very nicely the histologic correlate to a sclerotic rim. The bone at the periphery of this lesion is thickened compared to the bony trabeculae in the uninvolved portion of the fibula. So nice classic enchondroma. Now, as I mentioned, these tumors grow with a lobular growth pattern. At the periphery, they can undergo enchondral ossification. That is the histologic correlate to the O and C rings or the arcs that one appreciates radiographically. And here again, just looking at higher power, nodule of hyaline cartilage and chondral ossification. Enchondromas usually contain abundant matrix. It's most often hyaline. Small percentage of cases, the matrix may be myxoid. Not very cellular, and the chondrocytes have relatively small, round, and dark nuclei. In enchondromas of the digits, they can show increased cellularity, nuclear atypia in the form of nuclear enlargement with irregular contours. Cartilage biologically undergoes mineralization. This amorphous purple material represents the mineral. The type of mineral is calcium hydroxyapatite, the same mineral that's present in bone, and it can bind greater concentrations of the calcium hydroxyapatite in comparison to bone tissue. It is this which correlates with the irregular popcorn pattern of mineralization that one can see radiographically. This is not a low-grade chondrosarcoma. This is a cellular enchondroma arising within the digits.
All right, so treatment, we've gone through a lot of this. The things I think is important here is that sternum and pelvis tumors are malignant. You should not curette those things out. If you got a cartilage tumor in the sternum or pelvis, you should assume it's a chondrosarcoma and resect those. I did a literature review, and in the literature review, the best I could find was less than 5% of the cartilage tumors in the pelvis were malignant or were benign. So you need to assume that they are malignant and resect those. If they are asymptomatic, you follow it up, and I think all cartilage tumors that we've been saying, you need to follow those up. The higher risk factors, I will follow up a little bit more often. If you're going to excise these enchondromas, I think that you need to make sure you get all the cartilage out because they will progress. I will usually, if I'm taking out and I rarely take out enchondromas, but when I do, I many times put a plate in because there is a high risk of these things fracture if you really do an extended curettage. And we talked about the pelvic lesions. All right, so switching over to surface cartilage tumors, we'll talk a little bit about periosteal chondromas. And I think sometimes they're very difficult radiographically to tell the difference between that and a periosteal chondrosarcoma. But in general, periosteal chondromas, they occur in about 75% in the second and third decades of life, so a little bit earlier on. They are about 2 to 3 centimeters in size. You rarely see a benign periosteal chondroma larger than 6 centimeters in size. They cause local swelling, and because usually they're around the proximal humerus and proximal femur, there's irritation between the muscles, and you get some bursitis is how they usually present. I think that I don't think they commonly have bone pain. I think they have pain because they're up against the soft tissues, and that's what presents the pain. The majority of them are in the metaphyseal area. Here's just a good example of a periosteal chondroma, and you can see it. It's coming off the surface of the bone. There's no corticomedullary continuity there. You can see some stippled mineralization, very characteristic of cartilage there.
This is a nice resected specimen of a large juxtacortical chondroma. Appreciate that it's very well circumscribed, composed of this pale tan white hyaline cartilage, which is undergoing central cystification. This is the junction between the tumor and the underlying cortex, irregular but sharp, well-formed hyaline cartilage, which can vary with its degree of cellularity, comparatively hypocellular, increased cellularity in the more central region here. And like enchondromas of the digits, again, the threshold of where do you call something chondrosarcoma, one allows for a greater degree of cellularity and cytologic atypia before making a diagnosis of chondrosarcoma. Here we're looking at the surface of the lesion. This is the overlying perichondrium, and you can appreciate that this area of the tumor shows a greater degree of cellularity, can lead to, again, subjective interpretation between one pathologist saying, well, I think this is a chondrosarcoma, another feeling that it's still benign. My opinion, a benign juxtacortical or subperiosteal chondroma.
Okay, so we'll finish up on the enchondromas. When we talk about multiple enchondromas, the things that we worry about are they usually have deformity when you have these multiple enchondromas. They're short stature, the patients, but most importantly is what we're looking for is the Maffucci syndrome. So if it's multiple enchondromas, it's olease, and when you add to that hemangiomatosis, that turns it into a Maffucci's, which is increased risk of malignancy. Here's an example of olease disease. Again, most commonly you see it in the hand. It's usually unilateral. And again, you can see some common deformities you see with these multiple enchondromas. Remember, with olease, the risk of chondrosarcoma is reported between 20 and 25% of the patients. So these you need to follow a little bit more closely. I wish I could give you some strong recommendations of how to follow these things, but probably bone scan is what I do more often, and more often I will focus on the pelvic and shoulder girdle, because that's where most of the time you're going to see the malignancy transformation occur. Here you can see a nice olease disease affecting one side of the body. You can see the deformity as well on the x-rays and the bone scan. Here you can see where you see the common ones in the hand. You can see grade 3 scalloping, don't worry about that. You're not going to see a malignancy in the hand with these inchondromas. Here you can see the appearance when they occur in the hand. They cause these lobulations, usually right around the joint areas, and the cartilage protruding out these areas. And this is, again, benign cartilage formation.
And this is the amputation of the finger that he just showed the picture of, showing that the enchondromas can arise within the bone, within the cortex, and in some instances actually span a joint, being eccentric in location and becoming anchored to the adjacent bone. This is an example of Maffucci syndrome. Again, in Maffucci syndrome, it's not just hemangioma, it's a peculiar type of hemangioma known as a spindle cell hemangioma, and they are frequently multifocal and most often arise in the distal extremities, both upper and lower. And these areas that are discolored, sort of bluish, represent the skin that has been displaced by the underlying spindle cell hemangioma. With regards to malignant transformation that Dr. Lutzen was referring to, it's not just to the development of a chondrosarcoma in an enchondroma. They have a cancer syndrome, so they can get gliomas of the brain, pancreatic adenocarcinomas, ovarian adenocarcinomas. So those patients really have to be followed throughout their lifetime in search of a potentially developing malignancy.
Most patients with Maffucci's will not make it past age 50. Okay, now we'll focus on the tumor we love, the chondrosarcoma. And you know, the high-grade chondrosarcomas are the easy to diagnose. It's the low-grade ones that presents more of our challenge with us. So when we talk about chondrosarcomas, they represent about 11% of the primary malignant bone tumors. They're a little bit more common males to female. Remember, I was talking about earlier that 8 centimeters. When they get larger than 8 centimeters, up to that 9 centimeters, I'm much more concerned of a chondrosarcoma. Again, that average age is right around 46. Rarely do you ever see a chondrosarcoma below the age of 20. When we look at the chondrosarcomas, about 2/3 of them are in the trunk and the upper extremities. Again, it's the proximal areas. In other words, pelvis, proximal femur, proximal humerus is the most common areas we see the chondrosarcoma. About 8% of them are associated with a pathologic fracture. Usually they're central type chondrosarcomas. Peripheral ones that you see more common around the pelvis. And you can also have juxtacortical periosteal chondrosarcomas. So when we look at the radiology, again, I put that same scale back up there, but I'm using a different X-ray for an example there. So what we're looking at there is that there's an obvious cartilage tumor there. You see the arcs and rings there. You see at least a grade 2 scalloping, but when we look a little bit closer with some of the other scans, it's a grade 3 scalloping. When we look at the mineralization, less than 50% of the tumor is mineralized, and again, that's another red flag. So we got a red flag of grade 3 scalloping, less than 50% of the tumor is mineralizing, and then when we're looking at changes in the cortex there, and so look at the expansion of that bone. Benign cartilage tumors don't expand the bone such as that. So we know that, though, to me, this is a classic sign of a chondrosarcoma. When we look at this tumor a little bit closer, we get the bone scan, and you can see the bone scan has higher activity than the ASIS. That's certainly a concern that this is a chondrosarcoma. But I think the diagnosis on this one became easy once we got the MRI scan. And you can see on the MRI scan that the cortex is broken through. There's a soft tissue mass. This is obviously a chondrosarcoma. This is one that I would not biopsy. I would just resect this lesion. This lesion could not be a benign enchondroma, and we're not going to do any adjuvant treatment, so that would just be resected. Here's another lesion of the proximal femur. When you start looking at it, when we start weighing in all of our factors there, here's a lesion where much less than 50% of this tumor is mineralized. And you do see the arcs and rings here. And look at the bone is thickened here. And this is something that Andrew and I really agree on. You don't see that type of cortical thickening in benign cartilage lesion and expansion of the bone. That to me is a chondrosarcoma, and very little of this tumor mineralizes. I think that the rate of mineralization is something people miss quite often. Pelvic chondrosarcomas rarely have any mineralization within it. The less these tumors mineralize, they don't have the capacity, these malignant cells, to do the normal function in forming the mineralization of the cartilage. You can see the bone scan doesn't have much difference between that and the ASIS, but look at when you get the MRI scan, the lesion is about 10 centimeters in size, and more importantly, look at that peritumoral edema. You're not seeing that peritumoral edema very often in benign cartilage tumors. When you look at the CAT scan, we can see some grade 3 scalloping. So again, when I go through all of those factors, this one here, majority of all of those factors I was concerned about led me to believe this is a chondrosarcoma. And again, this was a tumor that we went ahead and resected without doing a biopsy because I felt so confident that that was a chondrosarcoma. Here's another example. This one's kind of a giveaway, that you can see that stippled mineralization. You know it's cartilage. You see thickening of the cortex there. You see a cortical breakthrough. I mean, that's not a benign cartilage tumor. That's a malignant cartilage tumor when you see that cortical breakthrough on that. Here you can see on the CAT scan very nicely that grade 3 scalloping, thickening of the cortex, soft tissue mass. And the reason why I keep saying these things, these are the consistent things you all need to follow. We can't just look at one entity. You got to look at all of these entities and put it together to make that diagnosis, and then it becomes easy when you look at the MRI scan. This is an obvious chondrosarcoma. There's no question in anybody's mind about that. Here, when you look at this chondrosarcoma, what's interesting, what do we see up at the top of that area? See a skip lesion up here? So you got to be real careful when you're looking at these things, and why we have to do scans of the entire compartment when we're looking at these tumors. Okay, careful, careful, careful. This is what happens, right? Somebody comes in, and if you have a hip fracture in Florida, what do? You get fixed. All right? People that went in there didn't even pay any attention to the mineralization in there, and you see this big radiolucency here, soft tissue mass there. Again, this was a chondrosarcoma, but the hip fracture was fixed, and you can see the pathology here. And the pathology shows, again, the glistening nodules of tumor that have eroded through the cortex, resulting in cortical disruption. Here's an intramedullary tumor that is completely encompassing the pre-existing cancellous bone. That translates into an infiltrative or permeative growth pattern, something that you see in chondrosarcoma, not enchondroma. Lastly, this is the histologic counterpart to the scalloping, where the cartilage has resulted in osteoclastic resorption of maybe the inner half of this portion of the cortex. Here's just an example of a cartilage tumor in the pelvis. Remember, pelvic tumors are more likely to be malignant. You can see a large soft tissue mass with mineralization of soft tissue. Here's the CAT scan, and look at that big soft tissue mass surrounding this thing. It's an obvious chondrosarcoma. Here's another one, just a large pelvic lesion. You can see this huge soft tissue mass associated with it. No question in anybody's mind, this is a chondrosarcoma of the pelvis. So we're talking about conventional chondrosarcomas, and that means the tumor is either making hyaline and or myxoid matrix. And grossly, we keep on referring to the lobular growth pattern, opalescent, sometimes blue hue to it. Areas that are very white represent calcification or conceivably, and chondroossification. Areas of the tumor that are appear to be very well circumscribed by reactive woven bone. I would wonder whether that could represent an underlying enchondroma. Rare example of a chondrosarcoma of a metacarpal here, the tumor originating within the medullary cavity, destroying the cortex, forming a circumferential soft tissue mass, and this is hyaline cartilage. This is an example of a myxoid chondrosarcoma, not as solid, more mucinous in appearance. Notice that the overlying cortex is thickened, and again, that is being caused by permeation of the tumor through the reversion systems
displacement of the periosteum, which is depositing reactive bone as it is displaced. Classic infiltrative growth pattern of a chondrosarcoma, replacing marrow completely surrounding the pre-existing bony trabeculae. Notice that this tumor is not very cellular, the chondrocyte's not that atypical, so with this image I would say it's likely a grade 1 chondrosarcoma in this image. This is an example of how chondrosarcoma can grow along and in the Haversian systems as they permeate through the cortex and butt against the periosteum. Low-grade chondrosarcoma in that the nuclei are no longer small, round, and dark like those in an enchondroma, little larger, have fine chromatin and small nucleoli, but no severe cytologic atypia. We're seeing now a higher grade chondrosarcoma. Notice that the chondrocytes are now multinucleated. Some have very enlarged nuclei, prominent nucleoli. This is getting into the range of a grade 3 chondrosarcoma. This is an example of a myxoid chondrosarcoma. Chondrocytes are not residing in lacunar spaces. They look more like spiders floating in a very prominent mucinous stroma. This is an example. Notice how cellular the cartilage is on this portion of the image compared to this area. Notice this area of hyaline cartilage is focally rimmed by reactive bone. I would interpret this is an underlying enchondroma which underwent malignant transformation, and this represents the chondrosarcoma, and you can contrast the two from one another. There are grading systems for chondrosarcoma. We use a 3-tiered system, and again, it's based on increasing degrees of cellularity, cytologic atypia. It's important to note with regards to mitotic activity, very uncommon to see mitosis in grade 1. The chondrosarcoma is still uncommon in grade 2. They are obviously most frequent in grade 3. One last word of caution, grade 3 chondrosarcoma, always be concerned that the tumor could actually represent a chondroblastic osteosarcoma, particularly if the patient is young, because pure or at least de novo grade 3 chondrosarcomas are uncommon.
Okay, switching to one of our last few tumors here, dedifferentiated chondrosarcoma, and I know we all know what that means. It changed not only from a chondrosarcoma, but to some other form of a malignant tumor, another form of a sarcoma, dedifferentiated chondrosarcoma. These patients do very poorly. There's different reports out from anywhere from a 10% survival to a 0% survival with these patients. They're very large and aggressive tumors. Mineralization occurs in about 50%. We're not saying that 50% of the tumor mineralizes. 50% of the time there is some mineralization within the tumor, and it's common to see a soft tissue mass associated with it. Here's a good example of what looked like there was a nurse that actually worked at Moffitt. She had this cartilage tumor with mineralization, had arcs and rings, and she didn't know she had a cartilage tumor, but she had a significant increase in pain in her leg. She said she had pain for several years. Then she got these x-rays, and you can see there's that cortical thickening here. You see that scalloping here. Less than 50% of the tumor is mineralizing. It's widened the bone there. There's some cortical thickening. You look closely at the CAT scan, you see it's not only grade 3 scalloping, but the cortex is completely broken through there. You can see less than 50% of the tumor is mineralizing. There's soft tissue extension out. There's peritumoral edema. All the things that we look at, this is a dedifferentiated chondrosarcoma. Here's another example of a dedifferentiated chondrosarcoma. It was a 30-year-old patient from Orlando. Ended up, he was hard labor, was working, had a fracture of his arm, x-rays were taken, and you see this one, barely any mineralization with it, and this is why I showed it. A few arcs and rings up at the top here, but not much mineralization at all. Large radiolucency, moth-eaten appearance, soft tissue mass consistent with a dedifferentiated chondrosarcoma.
So the histologic features of dedifferentiated chondrosarcoma include a pre-existing either enchondroma or low-grade chondrosarcoma, usually with a very sharp transition, abrupt change from the cartilage-forming component to what appears to be, in most instances, a pleomorphic high-grade spindle cell sarcoma. In my opinion, most of these are likely fibroblastic in phenotype because invariably you see intimate relationship between the cytologically malignant cells and the adjacent collagen formation. This is just an example of another one, very high grade, marked nuclear pleomorphism and mitotic activity. The dedifferentiated component can show different lines of differentiation. The most common is fibroblastic. Second most common is actually osteoblastic, where you get a high-grade osteosarcoma, again, juxtaposed to either an enchondroma, low-grade chondrosarcoma. Other unusual types of differentiation also can occur, rhabdomyosarcoma and angiosarcoma as well.
All right, finishing up with a couple tumors here. Clear cell chondrosarcoma. This is one that we talked about earlier. They're epiphyseal lesions. They need to be considered with giant cell tumor, chondroblastoma. One of the differences is with this lesion, there's usually a wider zone of transition compared to giant cell tumor and chondroblastoma. They occur in the 3rd and 4th decades of life, as you can see here, kind of that middle-aged group. Sometimes you can see some new bone formation in the center, and it's not uncommon to see a 1A border around the periphery of this thing because they're such slow-growing tumors. Here's another example of the little bit wider zone of transition that you see in a clear cell chondrosarcoma. You can see, does it stop here? Does it stop there? Does it stop there? This wider zone of transition, you see some bone formation within this lesion, but it's a classic femoral head example of a clear cell chondrosarcoma. And here's just the x-ray, and I'll have Andrew do the gross pathology. You can see there's that 1A border. Here is some bone formation within the center of this thing. And there's not any peritumoral edema that you see usually in that chondroblastoma.
So these tumors, and this correlates very nicely. This is that well-circumscribed margin, the 1A margin. This represents reactive bone forming the periphery. Notice in this example, the tumor has undergone secondary hemorrhagic change. Clear cell chondrosarcoma usually has areas of conventional Highland-type chondrosarcoma, which this represents, and then the remainder in this example is the clear cell component. So as the name implies, the neoplastic cells often have abundant clear cytoplasm. Another histologic feature that's invariably present is reactive or metaplastic woven bone that is lined by osteoblasts. So it's one of, again, the few cartilage-forming tumors in which within it there is a lot of non-neoplastic bone. Sometimes the chondrosarcoma cells can, if you will, overrun the osteoblasts, the benign osteoblasts that are producing the bone, that for at least pathologists, a diagnostic pitfall could lead to the erroneous interpretation of an osteosarcoma, which would be a problem because then the patient would likely get systemic therapy.
All right, last tumor. Secondary chondrosarcoma, such as coming off from an osteochondroma. Again, you see these things more in the proximal location. Pelvis is the most common area where you see these secondary chondrosarcomas. Here you can see this osteochondroma with a proximal humerus. This is a classic sign of an osteochondroma where you see that cortex of the corticomedullary continuity from the opposite side coming out. What you usually end up seeing with these osteochondromas is that the surface, the cortex of the surface starts breaking down. So it's not as often where you see this large cartilaginous cap, which you do see, but to me, radiographically, seeing a breakdown of that cortex at the bottom is more radiographic features I look for in this chondrosarcoma. Gross?
Yeah, and this gross finding is actually very interesting. You can see that they're cartilaginous nodules within the medullary cavity. I personally didn't see this specimen. I'd wonder whether this could be metachondromatosis, where you can get osteochondromas and enchondromas. Regardless, This would be the portion of the osteochondroma, would almost look sessile, and this large cystic component with some hyaline cartilage here represents the chondrosarcoma that arose in this underlying osteochondroma. This is another example of a large chondrosarcoma that arose in association with an underlying osteochondroma. This is obviously the resection specimen, and one can appreciate portions of the benign hyaline cartilage cap undergoing enchondral ossification, portions of the periphery here, and then in the chondrosarcomatous component showing increased degree of cellularity and cytologic atypia, and those are coming from more of these solid nodules, very thick cartilaginous cap.
All right, we're 6 minutes ahead of time. What's that? Median time of chondrosarcoma?
No, mesenchymal chondrosarcoma. Because that was,